And this is Dr. Nick from the ECG Academy. We're going to be continuing our discussion of the AV node and the electrocardiographic diagnosis of AV block. Just to review, the categories of AV block include first degree, where all the P waves conduct, it just takes a little bit longer. What's the normal PR interval? The normal PR interval should be 120 to 200 milliseconds. So anything longer than 200 milliseconds means that first degree AV block is present. Third degree AV block means that none of the P waves conduct, and we'll be talking about that in the last lesson of this series. Second degree AV block is a condition where some of the P waves fail to conduct, but some get through. Now, this chapter has to do with first degree AV block, and we have a cardiogram up here on the screen, and you can see that it is fairly regular. The QRSs look to be pretty wide apart if you count the rate. Here's one that lands on a heavy line: 300, 150, 100, 75, 60, 50. So we're talking about 50 beats per minute. And when we look for P waves, we do see that there is a P wave in front of every QRS complex. Now, what's the PR interval? Well, it depends on where the P wave starts. Look for the point where it leaves the baseline. And then the end of the PR interval is where the QRS begins. Well, I just want to show you that this ECG happens to have a fair amount of low-level noise. And these little jiggles here are the noise artifacts that I'm talking about. And so the question is, where does the QRS start? Does it start with this little bump, or does it not? And if you look at this QRS complex, it seems to have a little bump, but there is almost like a double bump. And if you look at this first QRS complex, there's no bump. So when you're trying to decide exactly where the QRS starts, if you only have one lead to look at multiple QRS complexes. And I dare say that the QRS really does start with the first upward deflection, that this first bump doesn't count. So if we say the QRS starts with the upward deflection, that would be about here. There are 4 small boxes on this side of the heavy line. There are 4 small boxes on that side of the heavy line. So if there are 8 small boxes times 40 milliseconds each, gives you 320 milliseconds. And that's the PR interval. It's clearly greater than 200, and so we can diagnose first degree AV block. If it's hard for you to count small boxes at this point, it's certainly a bit easier to take calipers to this tracing, and you can place the one tip of the caliper on the beginning of the P wave, the other end on the end of the QRS complex, and when you pick up the caliper and place it on a heavy line, you can sure enough count 8 small boxes, and that gives you 320 milliseconds. So indeed, first degree AV block means the PR interval is greater than 200, but you see, you still have 1-to-1 conduction of each of these QRS complexes. That's 1-to-1 with a little colon there. That's how you write it. Well, let's look at a couple of other examples. Now, here's a 12 lead, but I want you to concentrate on the rhythm strip down here on lead 2. If you kind of scan across, look at the forest first, you can see that the QRS complexes are quite regular, and they're at a rate of, I'd say a little above 75, maybe 76 or 77 beats per minute. You can train yourself to look at where the QRS complex lands on a heavy line, and look at how this one lands just a little bit to the left of the heavy line, and this one again marches a little bit more to the left, and this one a little bit more to the left. So you can see there's a progressive movement of the QRS complexes away from this heavy line. First of all, since it moves away from the heavy line gradually over the course of several beats, it means that the beats are regular. And it also lets you measure the rate in your head a little bit more accurately, because you know it's not 75, it's a little bit faster than that. So we're talking 76 beats per minute. We'll look at the P wave in 1 and AVF, and they're both upright. You can see those P waves right there. I think they stand out pretty nicely. You can see they're very tall and they're very sort of spiky, but look at that PR interval. If we take the QRS complex starting here, and we look at where does the P wave begin, it's almost 2 big small boxes. I think if you look really carefully, you can call this about 340 milliseconds of a PR interval. But notice that the PR interval is constant. If you scan across and look at every QRS complex, the PR interval is fixed. And so we can now make the diagnosis of normal sinus rhythm with a first degree AV block. That little degree sign, like the number of degrees in the temperature, That's how we sometimes abbreviate it. Some people will write out the words first degree, however you prefer. Let's look at a couple of other examples. Now here's a little bit more of a complicated electrocardiogram, and we're not going to get involved too much with the QRS complexes and what it shows. Just for you newbies, this is an example of a right bundle branch block, but we're going to cover that in the intermediate course going over 12 lead ECGs. But for now, let's concentrate on the rhythm. If you scan across, you see that the QRS complexes are quite regular at a rate of about 300, 150, 100, 75. It's somewhere between 100 and 75, closer to 75. I'd call it at about 85 beats per minute. And where is the P wave? If you look in front of the QRS complex, you really don't see a good P wave there. But keep looking, because here it is. You see the P wave occurs in this ECG just after the previous T wave. So here's the T, and then the P is sort of superimposed on top of it. And this sometimes will fool people into thinking that there's no P wave. But remember that T waves have a very gradual change in voltage, whereas P waves have a little bit more spiky appearance because they have higher frequency components to it. And so what you have to look for is a bump. And that's what you're seeing here, is a bump in the T wave. But you do have to look for it. It's not as obvious as you think. And if you look for the beginning of the P wave, it may be hard to find because it is landing on top of the T wave. But you can sort of extend it down a little bit and call the beginning of the P wave maybe here. And this QRS starts here. So again, we're talking about around 340 milliseconds of a PR interval. So here we have sinus rhythm, upright P's in 1 and AVF, a sinus rhythm with a first degree AV block. It brings up a good point. If someone asks you what the rhythm is, and you just say normal sinus rhythm, that implies that AV conduction is normal, that you have one-to-one conduction, that the PR is within the normal limits. When you have AV conduction disturbances like this, the rhythm should be normal sinus rhythm with first degree AV block. That's more of a complete label of the rhythm because, after all, you're trying to make a comment of what the entire heart is doing, both the top chamber and the bottom chamber. And this will become much more important when you have degrees of second and third degree AV block, of course. But just get in the habit of mentioning AV conduction when it's not normal. Well, the last cardiogram I want to show you has a very interesting physiologic finding. Well, we talked about the AV node and how the AV node delays the signal slightly. But what you have to appreciate is the degree of delay down the AV node has a lot to do with the atrial rate and has a lot to do with how quickly beats reach the AV node. And here's an example of what I'm talking about. If you look over this cardiogram, you can see there's a slight irregularity in that the QRSs do seem to march through, but then this beat comes somewhat early. You can see that this beat, if you had mapped it out, the normal beat would have occurred here. Instead, this beat comes a little bit early. We're going to talk about ectopic beats in a later section, but this happens to be an atrial premature beat because you can see a P wave that conducts to the ventricles. The P waves in front of all these beats are quite obvious. Following this premature beat, there's a little bit of a pause, and this interval is a little bit longer than the underlying heart rate. And so we refer to this as a compensatory pause. Now, this is going to affect how the AV node conducts, because the AV node will delay signals that are very rapid or signals that are early or premature. It's almost like the AV node isn't finished with the last beat, and if a beat comes in too early, the AV node takes its time to conduct it. These are upright P waves in 1 and AVF, so we're talking about a sinus rhythm. And this underlying rate is 300, 150, 100, 75, 60. So it's about 66 or 68 beats per minute. And when we look at the PR interval, it's clearly long. The PR interval looks to be about 240 or maybe 260 milliseconds and looks fairly constant in each of these beats until you get to that premature beat. When you look at the PR interval of the premature beat, it comes out to be more like 320 milliseconds. So you have about 240 here, but with the premature beat, you get a PR interval of 320 milliseconds. So it's quite a bit longer because the AV node wasn't ready for this beat. Now what happens is you get this compensatory pause. Compare the R to R interval here is 2, 4, 6, 8, about 960 milliseconds here. This interval is more like 2, 4, 6, 8, 10, about 1100. So the AV node had a little bit more time to recover. And look at the PR here. It's actually normal. The PR is about 200 milliseconds with this beat that conducted following a pause in the rhythm. But then with this next beat, the PR gets a little bit longer again and then becomes stable again at about 240 milliseconds, which is where it started. So the reason I show you this is so that you understand that the AV node conduction time will vary depending upon how quickly the rhythm is, and that the AV node at a certain rate will fail to conduct every impulse down. That means you'll get AV block. But in normal people, AV block normally does not occur spontaneously. Although it's true that normal people, and especially people with healthy hearts, can sometimes exhibit brief periods of AV block when they're fast asleep. We can see that on Holter monitors, but that's considered somewhat normal in those patients. But in the next chapter, I'm going to show you how AV node dysfunction can lead to failure of one-to-one conduction, and the AV node will get into a situation where it has to drop a beat every now and then just in order to keep up. And that's what we refer to as second-degree AV block, which is the subject of the next chapter in this section. So this is Dr. Nick for the ECG Academy. Thanks for watching.